Good morning, everyone. Welcome to the Why Amulet, a case-based review of Amulet's real-world performance. I want to thank everyone for jumping on at this hour, whether it's late in the day or early in the day. I think we've got a great presentation with with at least two very good speakers. I'm honored to share the virtual podium with Dr. Dipak Shah, who's the Director of Atrial Fibrillation at the Henry Ford Providence Hospital, who's co-director of the Structural Heart Program, Henry Ford Providence, and Dr. Professor Ole Dipak, who is a structural interventionist at the University of Copenhagen, Denmark, with several years of experience implanting left atrial appendage. Today's agenda will be this brief introduction. I will start off with talking about standard case closure with an Amplatzer Amulet. I'll go over the emerged data. Dr. Shah will have an excellent presentation on the closure of incomplete left atrial appendage, patients who've had surgical ligation, a very, very critically important patient population that often winds up in our labs. And Dr. Dipak will present a case of Amulet in an angulated left atrial appendage. So some really great presentations, some really great slides, and we'll definitely have time for questions afterwards. Just a little bit of housekeeping. This webinar is recorded and will be available for on-demand viewing. Questions can be submitted at any time through the Q&A feature on your screen, and a survey will be provided after the webinar. Please provide your input. Ultimately, we want to make sure that this is high yield for everyone on this call, and we're able to answer people's questions. So I'll start off. Topic, I want to talk about why Amulet as a left atrial appendage occlusion. I want to talk about data and clinical practice. So here's a picture of the Amulet device. The Amulet device features dual seal technology that fits virtually every left atrial appendage anatomy. There's a disc that provides an osteal seal and is connected to a lobe, which helps provide a dual seal mechanism of closure for all anatomies, whether it's chicken wing, inverted chicken wing, cauliflower, double lobe, windsock. Every year goes by, we have a new name for the appendage, whether it's whale tail, hammerhead. Allowing dual seal mechanism of appendage closure allows us to confidently close off the left atrial appendage and confidently get our patients off of oral anticoagulation. Again, there's the lobe and the disc, which allows a dual seal mechanism of closure. The lobe requires minimal depth and accommodates different shapes of the anatomy, and the disc provides a complete osteal seal and helps prevent more leaks. So we're not purely relying on the lobe for complete sealing. The devices come in a variety of different sizes, and they're measured by the lobe, anywhere from 16 to 34. The lobe length varies. At size 22, it's at 7.5, and then it goes up to 10. Minimum depth is 10 millimeters for the smaller devices, 12 for the bigger ones. And the disc up until 22 is +6, and after 25, it's +7. So again, I show this slide to show that there's a great variety of different devices that can help suit closure of a variety of anatomies. How is it different? Well, it does have a dual closure. It does have a higher range of devices that can treat a greater range of appendages. The depth of the landing zone can be much shallower, and the sheath description, we'll get that into a little bit. Lots of different studies ever since the device got, the Amplatzer cardiac plug got CE mark approval back in 2008. I'll briefly talk about some of the studies, but specifically the emerged left atrial post-approval study. So the FDA approved the Amplatzer left atrial occluder in 2021. Patients were enrolled in the emerged left atrial appendage registry trial. So this is a registry trial. This follows on the heels of the Amulet IDE trial, which was a randomized trial looking at Amulet versus Watchman. But this was real-world trial, and all of us who practice on a daily basis know that a lot of our patients don't fit into trials. So this becomes really important because we're able to see how it works when applied to our patients. Enrollment period was after 2 years. The first report of emerge occurred in 2024, followed by a learning curve analysis, and then looking specifically at prior failed left atrial appendage. Endpoints will be assessed until 2026, after which the evaluation of these patients will be done with follow-up using CMS claims linkage. Again, this was patients who were enrolled who received a Amulet occluder from 2021 to 2022, August to December. Outcomes or patient characteristics, medication regimens, closure status, clinical outcomes. In addition, case sequence comparison was done in patients who underwent implantation with early experience operators, moderate and high experience, and then also in patients who had a prior failed Watchman attempt. We'll talk about the endpoints and outcomes. Overall, about 5,600 patients had an implant attempt. At the 1-year follow-up, there were 3,000 patients. Age was about 77 years of age. 40% were women. The CHADS VAS score 4.7. 20% had a prior stroke. 2.7 was the Has blood score of the average, and about 2/3 of patients had prior significant bleeding. Implant success, 96%, with 97% of patients having zero leak post-implant. And if we look at 1 year, the whole idea is we want to get our patients off oral anticoagulation. At baseline, 90% of patients were on oral anticoagulation. At 1 year, 94% of patients were free of oral anticoagulation, with the vast majority of patients on single antiplatelet therapy. Key clinical events through 1 year: stroke was 1.7%, major bleeding 7.3%, cardiovascular death 2.7%, and all-cause death 8.1%, completely in line with the other large left atrial appendage registries at 1 year data. So this is a device that is on par with what we are seeing in other trials currently being published. There was a 79% reduction in ischemic stroke at 1 year in patients who had their left atrial appendage closed off. And there's high rate of complete closure not only at 45 days and at 1 year. At 45 days, 97% of patients had leaks had leaks less than 3 millimeters, and at 1 year, 97% had leaks less than 3 millimeters. So not only is there a high degree of implant success, this success in preventing leaks is seen out to 1 year in the eMERGE data. One really interesting tidbit here was that early experienced operators tend to have slightly lower implant success. Higher experienced implanters had a higher rate of success. Procedure time did drop. Fortunately, while the major events rates were low, they did decrease further with patients who underwent implants with higher experienced operators, and pericardial effusions also dropped with greater experience. So this is a device that has tremendous utility, and like with most procedures in the structural heart realm, the higher experienced operators have better outcomes. If we look specifically at patients who had a prior failed left atrial appendage, meaning they had an attempt with either Watchman or Watchman Flex, implant success was 83% in these patients who had failed prior attempts. And there's long-term safety that's seen both in the Amulet and the and in the eMERGE trial. Ischemic stroke was low in both groups. Peri-procedural safety actually improved in the real-world trial, possibly as more experienced implanters got their hands on this device. So key takeaways: there's a high acute implant success rate, with 96% overall and 83% in patients who had a failed attempt. High degree of closure at 45 days and at 1 year. High degree of freedom from oral anticoagulation, 94% of patients at 1 year. And adverse clinical events were low at 1 year, and were comparable to the Amulet IDE trial. Increased operator experience drives significant improvements in key areas. So that's the that's kind of the background. Here is the 5-year data that was just recently published at the HEA by Dr. Dipak, showing the IDE trial at 5 years. We can see that at 5 years, the clinical outcomes, Amulet compared to Watchman, we can see the overall stroke death was lower in the Amulet group. Major bleeding was similar. Cardiovascular death was similar but lower, and all-cause death was lower, not statistically significant. So very interesting data completely presented. Now, I want to start off into my case because it becomes very, very important to decide how we're going to attack these patients. Now, all these patients have a left atrial appendage that's completely different. What I like to do, and what I think is very, very helpful, is not rely on TE, at least up front, but to rely on CT scanning. CT scanning gives us a lot of really helpful information, not only on the size of the appendage, if there's any clot in the appendage, but also helpful in terms of whether or not there is where we should stick the septum, because an optimal septal stick really leads us to have a good sense of what the of where to attack the appendage. CT scan and 3D reconstruction can give us a sense of whether it's a chicken wing, how angulated it is, and what type of headaches we may run into before we get into. Now, I have the fortunate luxury of presenting an easy case. My colleagues, Dr. Shah and Dr. Dipak, will have really, really important cases. I look forward to hearing how they approach their cases pre-procedurally. What we like to do is I get bilateral femoral venous access. These patients are all done under conscious sedation in the cath lab. With the CT, I'm able to determine whether or not I need a 12 French torque view or a 14 French torque view, and I subsequently put a Cook seal, either a 16 or 18, in the right side, and then a long 10 French on the left side. Why? Because I like to do these cases under ice. And I think it becomes really, really important. And one of the strengths of the Amulet device is the ability to see it under ice and the ability to have successful implant under ice. So two separate sticks, both are pre-closed. This allows easy manipulation by one operator. We'll go ahead and clear the appendage with ice beforehand, making sure there's no clot. We'll also do a nice effusion check. Transeptal, would love to hear other people's thoughts. We tend to use the VersaCross transeptal device. It allows for really accurate placement of our transeptal. The wire is stiff enough to allow passage of our heavy sheaths, not just the torque fuse sheath, but also the when we do M tiers as well. Under ice, we can go ahead and see, here's an example of looking at what the septum looks like, how we're able to determine where we want to stick, and getting our VersaCross wire across. Now, the key point and one of the tips and tricks is getting the ice catheter into the left atrium. A couple of different techniques. One is always rely on your higher power. Some people will do a double transeptal stick, follow the wire across. What we tend to do is a balloon septostomy. Life is hard enough as it is, so using a 12 by 40 balloon, we go ahead and create a septostomy and then allow passage of the ice catheter over our wire. I found that it's helpful in the RAO to follow my wire across. Imaging in the left atrial appendage, imaging of the left atrial appendage from the left atrium is very helpful with ice. We can get really nice measurements. In this particular case, we can get both 45 and the equivalent of 135. We're going to measure not only the landing zone, which is the area where the lobe will sit, and we want to make sure that where the lobe sits, we have enough depth to go at least 10 to 12 millimeters beyond that. And then we want to measure the ostium to make sure our disc will sit at the tip of the Coumadin ridge and not extend into the posterior leaflet of the mitral valve. Ice will also allow us to use TrueView and TrueView glass to help assess the appendage and give us additional measurements. Mid-LA view with 45 and 135, which I showed a little earlier, will help us assess not only where the landing zone is here, and on that second panel, you can see the circumflex. And we don't even have to worry about how ugly the appendage looks distally, because we don't necessarily need to get in there until we talk about sandwich techniques, which will hopefully come up later. Our sheaths for the amulet, it's a 12 or 14 French sheath that comes out of the packaging like this. There is an adapter for the 14 French sheath to help flush it. There's also a steerable sheath, which allows you to not only torque the catheter, but allows flexion at the distal tip, which definitely is super helpful in big appendages, anterior appendages, and chicken wing appendages. And this is what the flexible or the steerable sheath will look like. It can go from a completely angulated view and with an anti-clock on the knob, give you a completely retroflex view. Again, it's not going to make up for a suboptimal transeptal stick, but it'll definitely help with optimal deployment. Here's what the device looks like when it comes out of the packaging. What we do, and I apologize, this looks a little grainy, in order to prep it, we hook it up to a pressure bag and we flush it out into a bowl to make sure there's no bubbles. Well, then again, this is what it looks like when we connect it. We connect it under a flush so that we minimize air. And then again, with ice, once our catheter is in there, here we're measuring an ostium of about 25. We're measuring a landing zone, I'm sorry, an ostium of about 37. We're measuring a landing zone of about 25 with more than adequate depth in there. We're going from the ostium, we're going 12 back, and that's going to be where the landing zone is, and that's where we're getting a measure of 25. So in this particular case, we're thinking about at least a 28, potentially a 31 device. Again, angiography becomes absolutely critical. Once we're in there, we tend to go ahead, either in the RAO views, in this particular view, it's an RAO cranial. Definitely like to see the distal marker band look as one line, get all the parallax out of it for a really good view. And again, we want to make sure not only we have a good picture of the landing zone, but also where our disc will sit. Overview of deployment. After we measure the left atrial appendage, we're going to unsheath to ball. Then we go ahead and advance to lobe, and then we unsheath the disc. We do a tension test, and then we release the device. So not dissimilar from other devices that are commonly used. Again, we're going to unsheath to ball. We may clock or anti-clock based on our ICE or TE. We'll advance to lobe and then unsheath to disc. And then we'll go over the close criteria for stability tests. I apologize, these videos aren't playing, but here's an example of unsheathing to ball. And unsheathing to ball is having hands on the cable and on the sheath to basically pull the sheath back. Advancing to lobe, what I like to do is having a single operator hand where one hand is on the sheath where I can clock or anti-clock, and my right hand is underhand where I'm advancing to lobe. And then we unsheath the disc by moving both hands to the back of the catheter. Here's an example of what this will look like under ice. Again, here's our pre-images. Our post-images, you can actually, the last image shows going from ball to lobe. It's a little skippy. It usually doesn't go that fast. You want to go a little slower, and you want to make sure the lobe is 2/3 past the circumflex, which we see here. And then we're doing our final testing here with this particular device, and we ended up using a 31 tension test so that your disc is elongated and looks like a deflated football, to make sure that the retention hooks have grabbed into the tissue appropriately and the device isn't moving. You definitely don't want to push in. You want to gently release. The close verification of stability, the C, you want to make sure the lobe is 2/3 past the circumflex. There's adequate lobe compression. There doesn't need to be an exact determination of what percentage, but you do want to see lobe compression, whether it's commented as a flat tire or a Roman helmet. That's adequate lobe compression. When it starts to look like a strawberry or something more smushed, that's too much compression, and you may not have a good seal. Orientation of the lobe should be in line with the axis of the left atrial neck. I also like to use O for offset, where both my attachment pin and my distal pin are offset from one another, which then confirms the orientation of the lobe. S is separation between the device lobe and the disc. E, elliptical, it gives you a concave disc. Once these are all met, and after doing a tension test, the device can be released. And here's another example, and more magnified. We can see the pulmonary vein off to the right. We can see doing the tension test and then releasing the tension so the device sits in there and that there's no flow. So take-home points, the randomized control trial data and registry data test the safety and efficacy of the Amulet device. We know that increasing experience leads to improved outcomes. The device design itself allows treatment for a wide variety of anatomical variants. And as we move to a more minimally invasive approach in doing these cases in the cath lab and the MP lab with conscious sedation and eliminating TE, this particular device truly lends itself to additional procedural efficiencies with lending itself to intracardiac echo. And just a quick little data in terms of intracardiac echo and TE, looking at the NCR left atrial appendage registry. Basically, events are about the same, all-cause death, no significant difference. Pericardial effusion was just a tick higher in patients who underwent ICE-guided implant. Again, this was early experience. Hopefully, as more and more implanters use ICE, this will actually come down as well. So with that, I'd like to thank you for your time and your attention. I'm happy to answer any questions now, or we can dive into Dr. Shah's talk and assess any questions or answer any questions as they come in. Thank you for your time and attention today. All right. Without any further ado, then, I have the distinct pleasure and unfettered honor of introducing Dr. Dipak Shah from Detroit, who has a wealth of experience in left atrial appendage closure. He's an experienced electrophysiologist, the go-to guy in the Detroit area. And I'm looking forward to hearing his talk on closure of incomplete left atrial appendage after surgical ligation. Dr. Shah, it's all yours.
Hey, thanks, Atman, and thank you for doing the heavy lifting of kind of covering a lot of material so I could focus on kind of a smaller segment here. Thank you for having me here. Here's my disclosures. And so, you know, I like to talk about, you know, before I get into incomplete surgical ligation, just as Dr. Shah had mentioned, that the left atrial appendage is a very complex structure. There's many morphologies. I mean, I'll talk about a few of the more common ones, but, you know, we keep coming up with names, whale's tails, hammerhead, as he said. And so, you know, in Michigan, we got bad press a few years ago for potholes. And I think there's many ways to deal with this, right? You could put a bunch of asphalt in there and just smash it down and kind of move on with your day. And you know, with the weather elements that we have here in the Midwest, over time, erosion and shearing forces will take place, and this will gradually wear away, and water will kind of get in, and this pothole will reform. Or if you take a little thought to it, and I know Dr. Shah mentioned the CAT scan, really thinking about how you're going to deal with this, you could plug it and then with another component really seal it up. And I think the bottom kind of repair is going to last a lot longer and be there and have less erosion in another pothole. So that's what I like to think about these dual closure devices, that they give us more opportunity to close all kinds of structures. And so when you look at these structures here, again, just 5 common ones: chicken wing, windsock, seahorse/swan, cactus, cauliflower. why I think the Amulet has such advantages over a single closure is that there's multiple reasons, but the more complex it is proximally, the more difficult it is for a single closure. So, Dr. Chris Ellis will tell you numerous times that if you look at the seahorse or swan configuration, and Dr. Dipak will probably get into this with specific examples, that when it's angulated like this, you can put a lobe in or try to figure out how to do this with a single component. But if there's any sort of tilting or rocking that happens at 45 days or later on, there's going to be some sort of peri-device leak. And so with all of these issues, whether it be highly angulated, whether it be shallow depth, whether it be heavily pectinated, I think the Amulet gives you a lot more opportunity to have that confidence that you're going to be able to close it. So this is a cartoon kind of just giving you a few examples here, right? So on these angulated appendages, that any sort of tilting where the device just gets sucked in or rotated, you can have leak either on the inferior aspect or the anterior aspect. These whale's tailed, right? When you have a bifurcating appendage, you have to self-select, right? So you pick which lobe you're going to put the Watchman in, and then your goal is to oversize and expand it out. And the problem with that is you get a huge shoulder, and sometimes it gets sucked in, and then you're left with a significant leak. These proximal lobes, they're very challenging for these Watchman devices to handle because you're stuck again, right? You implant too shallow, you're worried about stability in a shoulder. You implant too deep, this is going to be left uncovered. And I'll show you a schematic later on where these anterior pectinates or these lobes are left behind. The other example, again, is a shallow implant or something that's heavily pectinated, right? If it's heavily pectinated, right, and sometimes you can't appreciate how the pectinate is going to interact with the device. And so if you put a Watchman in, often it turns into a hot dog shape. And what you have is you've got compression all through, but you've got a circumferential leak around the device. And so you're really in a bad position with that type of implant. So this just is a cartoon again showing an implant on the top panel at implant and then 45 days later. And this is showing your TE views of 0, 45, 90, and 135. So if you look in the high angle view, which is panel D here, you can see that at implant, they had mentioned they struggled and finally got into an adequate position, maybe right here on this mitral side that have a small little leak. They're hoping that it seals off. And then what they see on that 45-day TE, and this is not all too uncommon, is that the device gets sucked in a little bit deeper and kind of rotates a little bit counterclockwise. And now you have a significant leak, and now you have flow into the left atrial appendage. This is what I alluded to before, these anterior pectinates. Again, this area here is where Watchman really struggles, because what are you going to do with this, right? This is the proximal area where Watchman has a difficulty covering this, right? So if you go any more distal, again, you're going to leave this significantly behind. Any more proximal, you're going to have a huge shoulder, and they already have a mitral shoulder, as you can see from here. So you're worried about stability, you're worried about your shoulder. Usually you see this on angiography as kind of like a comb, like these little strand-like structures, and you can see this here that's left behind. So when you look at the IDE trial and when you look at the Matthew Price paper that really looked at peri-device leak, and if you focus on Amulet versus Watchman, Amulet was significantly better. So most of us, I would say all of us, really don't deal in the 5mm realm, right? No one's really leaving someone at implant with a 5mm leak. That's just not standard of care anymore. And what we know now is that we really strive for 0mm leak at implant. And that 0 is better than 1, which is better than 2, and then better than 3. And as Dr. Shah had mentioned previously, if you look at Amulet versus Watchman on the right here, you can see that it's significantly in favor of Amulet to have 0mm leak, or at 3mm or less, 90% of the patients in the Amulet arm versus 78% in the Watchman arm. So again, this dual closure really helps in terms of dealing with this leak. So now getting kind of incomplete surgical ligation is really just one component of a proximal appendage where you're struggling with. And so when you look at this paper here, they talked about surgical ligation with a suture bound technique. And again, usually that's not as good as a clip or amputation of the appendage. But in this paper, again, only 64 to 66% of patients had complete ligation, which was panel A. If you look at panel B, which is this incomplete surgical ligation where you're left with a neck and flow into the appendage, and that was 24% of patients, and about 12% of patients was this left atrial appendage stump, where it was this broad-based stump with about greater than a centimeter of depth. And when you looked at this paper here, what they found, which was significant on multivariate analysis, was that panel B, which was incomplete surgical ligation, these patients had a 24% risk of CVA or systemic embolism compared to the other morphologies. And again, this narrow neck and all of these things are a big issue. We see this all the time. You know, the surgeon after mitral surgery or all of this stuff does their technique. And if you find out later on with TE or some sort of imaging, you're sort of seeing this. And I definitely think that the Amulet with its dual mechanism is really the go-to closure for this kind of issue, as it is for any proximal appendage issue. Because what you're gonna have to do here is get the lobe past the neck, and then you'll just put the disc out in this area, and you're gonna have this kind of drywall or flush repair. If you stick with a Watchman, you're either gonna have to deep seat the Watchman inside, you're gonna leave the neck behind, or it's gonna kind of give you this big kind of shoulder out into the left atrium, which I just don't think is ideal for these patients. So this is a case we had here, just playing this case here. You can see on the left the pigtail, and there's a little neck here, and then you can see flow into the appendage here. And you can see on this TE view here, again, you can see this little opening right on that bottom rear, right near the circumflex, where there's flow into the appendage. So you'll be surprised that it was very easy to get the ball configuration, as Dr. Shah had said, from the proximal part right past the neck. Because when you see that leak in multiple views, there's definitely a larger hole that can be appreciated. And obviously CAT scan can really kind of quantify that for you in good detail. But we got it passed very easily. And then on the panel on the right, we've deployed the lobe. So we deployed the lobe past the neck. And then on the next image here, you can see that we've got the disc on the other side of the neck here, that there is no leak anymore, and it's completely sealed off when we have it tethered here. And then when we release the device here, again, we've got this sealed off nicely. So again, this is just an example here before Dr. Dipak gets into his talk, to kind of show you that this Amulet device with its dual closure is really excellent at handling proximal difficult appendages, whether it be angulated, heavily pectinated, or incompletely closed from surgery.
Yeah, thank you, Dr. Shah. I mean, I think I'm going to take over from you. I think my talk is going to go a good prolongation of what you have been discussing and presenting. I think to introduce myself, I'm a structural interventional cardiologist from Copenhagen, Denmark. And I have experience since around 14 years with LAA closures, and actually more than 10 years also already with both devices, either the Watchman, initially Watchman 2.5, then the last couple of years Watchman Flex, and then also in the beginning was ACP and then the Amulet device. So I have quite experience with both devices, and it's here I think I want to share you my experience of use of Amulet indeed in challenging LAA anatomies, as I think indeed that the Amulet device is an extremely versatile device. It can be used in a lot of difficult anatomies. And here I listed a couple of them, made some drawings of it. So what do I consider as challenging anatomies? So I'm not going to focus only on angulated LAAs, but very often this is the case. So sometimes you have a combination of a large ostium, a long PV ridge, and an angulated LAA, but you can also have the multi-lobe LAA. You can have proximal or ostial trabeculations, as mentioned before by Dr. Shah as well. You can have the inverted or reverse chicken wing. That's an acute angulation too, but in the other direction. You can have a strong tapering of the LAA, and you can also have very shallow LAAs or seahorse LAAs. So in the next couple of 15 to 20 minutes, I'm going to go through some cases. So it's really case-based what I'm going to show you. And please interrupt me, Dr. Shah and Dipak, if you want to have some questions for me. So first, I'm going to show you a couple of cases with really acute angulated LAAs. And this also very often coincides, not always, but often coincides with either the challenge of a large ostium and a long PV ridge. And I want to show you the differences of how these two different devices, if we want to focus on Amulet and Watchman Flex, behave in these anatomies. So this is the first case. You see it's an acutely, as my colleague, Dr. Shah as well, I'm a big fan of using cardiac CT as a pre-procedural planning tool. It's really extremely accurate. You don't come for surprises during your case. It's by far the best pre-procedural planning tool. So cardiac CT I have, and you see here it's an acute angulated appendage with almost no landing zone. Immediately the wing of the chicken wing, as we call it, and you see it's also large dimensions. So the LA ostium is around 34 millimeter, and then the landing zone. That's also important. If you use CT and you go for the landing zone for your lobe sizing, I kind of advise to look for your perimeter-derived mean diameter, which is in this particular case 23.4. And then we want some kind of 20% compression. So then I end up easily with a 28 device. I check whether the maximum diameter of this landing zone is also not larger than this attempted or the device size I would take, so the 28. So that's going to be my device I'm going to take in this particular case. So here you see, this is the case actually from this Friday. I do an injection. You see, indeed, it's a large, relatively large ostium with almost no landing zone, extremely angulated right away. If you're going to go implanting a Watchman here, either you put it really deep and you leave an uncovered ostium in a way, or you go for an ostial implantation and you end up with a massive shoulder. So here what I did at 28 device, I was kind of, you have two options in this anatomy. Either you implant your lobe of this, your Amulet device really perpendicular to the central axis of the LAA, like I did here, and then you have a nice compression, and then a very slow, gentle expansion of your disc. You can do that, or if an alternative is to bring in the device as a sandwich, so you bring in the lobe really anchoring parallel with the chicken wing. However, I would say a sandwich technique you can do, but it's prone also more for leak if you check it with the CT. So here you see, this is a nice closure in a way, but the disc is a little bit retracted into the appendage still. So I could decide to bring in this device implanted a little bit more proximal and have really closure of the entire ostium. But I think in this particular case, where I was really afraid of the acute angulation, I kind of tended to accept this and keep this smooth part uncovered. However, there's other cases. For example, this is the case from a bit longer time ago, also acutely angulated. As you see, it's a 90-degree angle, also relatively large, an ostium also of about 34 millimeter, also probably for an 828 or a 31 device here. And then this is a small recording here from a live case. As you see, it's from maybe more 1 or 2 years ago. So what we do here, you see on the left bottom, we see the ICE images. So the ICE catheter is parked into the left upper pulmonary vein. I do also all my appendages. I think my last 700-800 appendage closures have been done with ICE guidance only, so just in local anesthesia. You park your ICE catheter in the left upper pulmonary vein. Here you see the ball shape of the amulet. It's kind of nice, 1 centimeter distal of the circumflex. You see on the ICE catheter very nicely the circumflex artery there in the left corner. And if you're 1 centimeter distal of it, then it's the moment to kind of, you see all these maneuvers are going really slow expansion of the lobe here. And then this is the triangle shape. At this particular moment, if I want to keep the distality of my device, I even give a little bit push on my delivery catheter. So now the disc has been made. You see this case was done even with some fusion imaging of the simulated device. I had some FEOP simulations, which is really nice. On purpose, I went 1 or 2 millimeter more distal than the simulation. I was happy with this kind of position and the compression I had. And normally then we go continue here. And now we're gonna make the disc. Yeah, you see, this was a very angulated appendage. So what you can do is now I will slowly start to expand the disc also. You will see that all these maneuvers, I would say, I would advise to do it slowly. There's no need to go rushed and to really expand this device very quickly. That's actually not advised at all. I recommend it. Here we're discussing, I think, on the eyes, whether we're really sitting nice. You see already that the lobe sits actually 90 or 100% distal of the circumflex artery and sits nicely just in the turn of the wing. Here you see again if you look nice to the ICE images on the left bottom corner, then first the disc is actually retracted in the appendage, but then I do some tug test. I tug a little bit on the disc, and then I kind of nicely pull out the disc out of the appendage. So then you can really nicely have an ostial closure with this device, which would absolutely be impossible with a single plug device. So now you see, I will still give a little bit of contrast to confirm, and you will see indeed that the disc nicely occludes all the way up to the ostium. So this is an advantage definitely of a double component or a dual component LAA closure device that you can have your anchoring part, your lobe deep into the appendage, and then your lid, your disc, nicely shuts off the ostium. So going further, some examples of also acutely angulated LAAs done with Watchman flex. Again, here you see it's almost no landing zone. It's very acutely angulated. So then you already know you either have to go really deep into the appendage and you leave some proximal part uncovered, but the problem is that there's also some trabecals, or if you want to go really proximal, the problem is that you have a very shallow LAA. You don't have a lot of, it's not very deep there. So you see the struggle here. This is the case. You see it's a large ostium in a way. It's a wide open tapering like a trumpet opening ostium. And then you see, if I continue here with my Watchman flex device, here you see that I'm actually creating a new cul-de-sac, as we call it. So I'm not having an ostial closure at all. I make even some, this is prone for thrombosis, and you also even have some device shoulder. So this is not ideal, and I think you can do better with a dual component device. Here again, a CT, another case, also acutely angulated. Don't be distracted. This is not a very shallow LA because this is just missing contrast. I will show you later. So this is again, you see it's an acutely angulated LAA with almost no landing zone, an acute turn, also a relatively wide ostium. And you see already on the sheet that this was done with the Watchman flex. Here I went first distal in. I didn't want a big shoulder, but then the problem is, as you see, I left some trabecals uncovered in the proximality of the LAA. So I was not happy. I thought, okay, maybe I go better for a bigger device. Then I sized up to a bigger device, and still, despite going for a bigger Watchman flex, now I even have a protruding shoulder, and I still have these uncovered trabecals, and I even make a new cul-de-sac. So in a way, I'm there struggling with this anatomy to really close it properly with a single plug device, I would say, and retrospectively, I would have maybe gone better for this anatomy to close with a dual component with the Amulet device. So continuing on this, and other anatomy or morphology from the acute angulated LAA is, of course, the reverse or the inverted LAA. This can be very challenging. I would say if I have a reverse chicken wing, I like to know it beforehand on my cardiac CT. And if you have an inverted or reverse chicken wing anatomy, it's really important. It's really key, if you want to be able to close this LAA, that you go for an extremely inferior puncture and you will actually avoid a posterior puncture. You just go for a very central and extremely inferior puncture, as inferior as you can. And also there, I would say eyes guidance helps with obtaining an extremely inferior puncture. You can puncture more, or you dare to puncture more inferior if you do it eyes guided than if you do it TEE guided, because there you don't really see the inferior edge of your fossa ovalis. So here you see this is the challenging part. So it's a very vertical takeoff of the appendage with the reverse chicken wing. What you can do with the Amulet, if you're working with the Amulet, which is nice with this device, is that you can use this kind of reverted or inverted chicken wing, that kind of wing, to kind of stabilize your lobe. So here you see I have a partial sandwich, so that lobe sits nicely partially into the wing and gives some stability to my device. And then I have the nice disc to really cover up completely ostial. So I do here a nice tuck to check for the stability of my device. It sits rock stable, and then I release it. Yeah. And here you see this is a 3-month follow-up CT in this particular case, which was this challenging reverse chicken wing. And you see I have a completely nice occlusion of my entire appendage. Yes? So the ostium is completely covered and the lobe sits nicely into the chicken wing. Going further, multi-lobe LAA, I'm not going to show you cases of that, but just some theoretical drawing here. You have, indeed, you already heard, you have whale-tailed or swallow-tailed. Well, these whale-tailed anatomies you sometimes have. I would say as long as you have some kind of proximal to the whale tail, you can close this with any device. But if you have almost no existing neck and immediately a whale tail, yeah, of course, it makes sense that here you have an advantage with the Amulet device where the lobe actually only takes 10 to 12 millimeters. You can nicely anchor this distal of this waist and then have a nice closure of the ostium with the lid, with the disc of the Amulet. In a swallow-tailed appendage or a double lobe appendage, well, then of course it all depends from how proximal the carina of these two lobes is. If it's not very proximal, it probably lets it close with both devices, although I would still favor myself a double component. But especially if the carina of these two lobes comes very proximal and you only have around 10 to 12 millimeters proximal to the carina, to the ostium, of course it's a no-brainer, I would say, that you have an advantage using an Amulet device. Going further in ostial trabeculations, I also have you some examples here. This looks a relatively easy appendage, I would say. It's a bit angulated, but not too terrible. I thought this was kind of closable. There's clearly some angle, kind of a chicken wing. We have a perimeter derived here of the ostium, because I was probably going to go here for a Watchman flex, I see. So I measure kind of my ostium here about perimeter-derived mean 24.8 and a maximum of 26.5. So I would probably go for a 27 Watchman flex here. So this is from a live case here. You see what I did here, you go in with the Watchman flex, and what I had I couldn't go deeper. I had some shoulder, and again, what I showed you before, I had some trabecals uncovered in the proximal end. So this, of course, was a okay result, but I wouldn't call it more than okay. It's just kind of a suboptimal result. I think with an Amulet, I could have gone for a more ostial closure for this device. Here, this is then some shallow LA. Of course, if you have a really shallow LA in the proximality, as you know, if you work with a Watchman flex, the larger device you take and you have some compression, the device elongates. You need very often more than 12 millimeter of depth for your anchoring components. So here, this is a relatively shallow appendage. It's kind of a stump of an appendage. You see also relatively large. The ostium is measuring up to 35 millimeter, and the landing zone about 28 by 25. So here, as you see, this is the patient post-TAVI. I don't know, this is not running. The loops are not running, but that's a shame, because you can see actually what I wanted to show here. Now it's not visible because the loops are not running, but you can see that I'm struggling also again with quite some shoulder and relatively uncovered ostial trabecals. I hope the next one is the loops will be running. The scene is, this is also a case from last Friday. You see a relatively undeep appendage. Yeah, this one is luckily going. So it would be possible to do maybe with both devices. On the other hand, you see the distality is full with trabecals. It's fully trabecularized, so there I cannot really count on putting a device in. So then in a way here you see the markers. I don't have more than 12 millimeters of depth in this appendage. So I think what I did is I went in with an Amulet, which you can nicely implant in this proximality, and then you can nicely implant here slow expansion of the disc. And then here you see the nice injection. You see completely the disc nicely covers up the entire ostium. You have no leaks, and I'm sure with the follow-up CT you would have complete closure of this device. Yeah. So then one of the last ones here, I want to show you a seahorse LA. What's a seahorse LA and what is the complexity of it? Well, the problem with the seahorse LA is that you have a relatively wide ostium, and there where the landing zone is just less than 10 millimeter inside the appendage, it's already a lot of tapering. Yes, and then you have some kind of, even on top of that, some reverse or inverted LA at the distal end. That's it looks really like a seahorse. Of course, that's a problem to get some really good anchoring. Unfortunately, this cine is not running, but here you can at least see that that's the problem here. You have a big step in LA dimensions. It's problematic to where to land the device, and should we use a distality, yes or no? I hope this runs. No, it's not seen, it doesn't run, but you can see here I nicely implanted just on the tapering part. I can have some nice compression on the lobe. And then here, luckily, there's some contrast here. You see, I check whether I'm good deep enough. I even use a little bit of the distality, the reverse checkering, to really have some good anchoring and compression on my lobe. And then I can nicely get the disc off, and I have some nice ostial compression. This would be a very, very challenging with just a vascular plug, just a simple, LA plug device. So with that, I would conclude here that indeed, I think Amulet is really a great device for LA closure. For me, I think any complexity you have, whether it's large ostium, long PV ridge, very angulated LAs, multi-lobe, strong tapering, ostial trabeculations, seahorse, shallow LAs, I think all these appendages can let them close with an Amulet device. So for me, this is, in a sense, more versatile than just a single plug LA occluder. And with that, I want to conclude, and of course, open for any questions.
Awesome. Thank you, Professor Dipak. That was a fantastic tour de force. I'm really happy that we were able to get through so much great content. I certainly learned a lot and would love to jump into a few questions here that have popped up. So the first question is, how are we approaching patients who've had reported surgical isolation in terms of testing for complete closure? Do we wait for a thrombotic event to trigger imaging, or do we just review the in-procedure TE versus during CABG? So Dipak, I want to throw this to you first. It's kind of a great question. You know, we think that once the surgeons can close off the left atrial appendage, we don't have to worry about it. But what's your pre-procedure approach in terms of how do you test, how do you approach these patients, and what your next steps are?
Yeah, I mean, I think based on the LAAs data, you know, the data suggests that we use anticoagulation in all these patients. And obviously, a lot of these patients who've had surgery are high risk. So you're kind of stuck because really looking at the guidelines, you really, you know, the US guidelines becomes quite confusing. So on a lot of these patients who can't be on anticoagulation or whatever, we'll get a CAT scan. And I think, as you both have said, the CAT scan really doesn't lie, right? And if there's any sort of remnant, then to really more safely treat the patient, you know, either keep them on anticoagulation if there's a remnant, or you're going to close it with an Amulet device. And that's been our approach.
That's awesome. Thank you. Professor Dipak, do you have anything to add to that in terms of how you approach these patients?
No, again, I mean, I think indeed, if these patients post cardiac surgery and they have a remnant open LAA, I mean, my first step would definitely be to ask for a cardiac CT. And this cardiac CT is great because there are a couple of things you can get out of this cardiac CT. First, you have a real objective imaging that there is still contrast going into this remnant LAA. Secondly, you can do some sizing, and also, most importantly, out of your cardiac CT, you can get your optimal fluoroscopic views. And this is really, really key for success. And to make these cases really easy, you can calculate on your CT which angulation with your C-arm, for example, which REO angulation. Is it a 30 REO or 45 REO? Is it caudal or cranial? This can be varying from patient to patient. So you can calculate this and preview this on your CT. And then you go into the case, and actually you can anticipate upfront where this remnant LAA is going to be, and you make your life so much easier. Yes, it's not just a random fishing from the remnant LAA. No, you know exactly where it is, and you go in there and you know the size already of the device. And I also, indeed, I think my favorite device is for sure also, I don't think it lets itself close with a Watchman Flex device. I mean, typically these are relatively small. So either you take one of the smaller Amulet devices, and even if it's that small, you sometimes use these vascular plugs for these cases.
Oh, fantastic. Another question that popped up is relating to delayed perforation of the pulmonary artery. And whether Amulet has any link to that. I know we definitely look at CTs in all of our cases, and we look at the proximity of the appendage to the pulmonary artery. But what's your practice and what's your experience to try to minimize perforation? Or is this even a concern for you, perforation of the pulmonary artery with Amulet?
Yeah, if I should go first, please go ahead.
So we look at it. I think with the anchoring wires, there's a possibility, and obviously there's reports in the literature that it can occur. I think obviously CAT scan will give you a good modeling, but I think if you do TE, right, you're looking at the high angle view often, the 135 angle view, and you can see how close you are to the pulmonary artery. That will help us adjust our technique. And as Dr. Dipak said, often there's some play with the Amulet because of your landing zone that you can be a little bit proximal or a little bit more distal, and you can angulate your lobe. And we use a steerable sheath, and that steerable sheath allows us to play with that a little bit to make sure we're not directly opposed. And you need both the distal and the middle portion of the lobe, and that's where the data comes from, which puts you at a higher risk of possibly causing pulmonary artery injury. So by looking at the CAT scan or a TE, you can try to tailor it.
I agree. I mean, on CT, you can see the proximity of the pulmonary artery with the landing zone of your LAA. And if you would have any concern, either you go for another device, or you also should avoid what I would say is over compression of your device. Yes, I mean, typically it's an issue if you have over compression of more than 30% of your device, then these anchoring barbs, they can extend quite far. So I would say try to avoid over compression of your device, and you can see it on CT as well. Indeed.
Professor Dipak, you had mentioned you used FEOPS. Do you use FEOPS assessment and same thing, Dipak, do you use FEOPS for all your cases, some of your cases? Do you find it helpful? In what areas do you find it most helpful?
Well, look, because I have cardiac CT up front for my cases, and I have them typically even a couple of weeks before, I can see which cases are challenging or not. And if I see a challenging appendage anatomy, you can easily submit these cases to FEOPS, and they come with these simulations. What they typically do is they simulate two different Amulet devices, two different sizes and two different implant positions, either more proximal, more distal, or you can even ask for a sandwich position also, so you can interact with the company and ask for other simulations. What you get out of this is you see the compression, you see what the anchoring, if the anchoring is proper enough, but they also simulate what the risk is for peri-device leak. So this gives really extra information. How I use it, it's not that the simulation necessarily tells me this is the one and only to go, but I can exclude options. I know up front, for example, okay, an Amulet 25, it's not going to give me any compression. So I'm not even, then you don't have to try this even on your case. So typically I end up with maybe two configurations that I know these are possible options, and I try to perform and execute that during the case.
Awesome, thank you. Another question is from the audience is, do we need to be coaxial between the disc and the lobe for stability, or is some angulation acceptable? Dipak, do you want to attack that one first?
Yeah, I think, I mean, some angulation often, if you're doing a sandwich technique or something like that, sometimes it leads to that depending on things. But I think getting back to what you both had said, I think for the people who are implanting this device or starting to implant this device, number one, coaxiality on this is imperative. Right. I mean, you know, I have to say, Dr. Dipak made a perfect comment saying, look, with the Watchman, some of his implants were okay. And when you say that, that's what we've been used to because it's been out in the US longer. Like those anterior trabeculations or pectinates, they have been told by us for a long time, that's the best you can do, leave them behind. With the Amulet, if you want a complete closure at the ostium, like Dr. Dipak showed on a lot of his cases, look, coaxiality matters. The transeptal matters. That wasn't as emphasized with the Watchman as it is with the Amulet, because if you stick lower or more anterior or more posterior, depending on how your appendage is, I think you get that better coaxiality and the chance for no cul-de-sac, no anterior pectinates, no peri-device leak. So I think this is more of a perfect implant. So I think coaxiality is very important.
Fully agree. And if I can add on this, I mean, coaxiality is absolutely the number one thing I want to obtain, because if you can get really proper coaxiality of your device, that's the recipe for complete closure. I mean, typically if you have off-axis implants, that's the cases where you have remaining residual leaks. Yes. So even, of course, it's very forgiving, the Amulet. I mean, you don't have to be perfect with your coaxiality with your lobe, but if I can do it, like the first case I showed you, I had to make a compromise. Either I go for a coaxiality implant, I had some retraction of the disc in the appendage, or I went for a full sandwich implant. Well, I know from follow-up CTs that I have on these patients that if I do sandwich implants, it's good, it's fine. I can occlude and get the disc at the ostium, but there is quite some percentage of some, I don't say it's important leaks or clinically important leaks, but at least there's some contrast remaining going into the appendage with some follow-up CT at 3 months. Whereas if you do a coaxial implant of the device, typically your residual leaks or your patency, as we call it, the patency on cardiac CT is really, really low. Yeah, so coaxiality is number one for any device. If you can obtain coaxiality, you should do it.
And Atman, can I add one thing here? I think we talked about leaks and coaxiality and success, but you know, getting back to your slide where you talked about experienced operators having less pericardial effusion, I think this adds to that as well. Because what happens is you guys really deploy slowly. I think it's very important. But if you're not coaxial with your implant, you have a lot of people rotating in a triangle configuration or doing all of these things where almost they're too distal in the appendage because they're not coaxial. So they're using a lot of stress. And then the lobe takes these weird configurations and different things. And I think that's what leads to pericardial effusion a lot, is that they're not coaxial.
Exactly.
Making these manipulations.
Exactly. You make a very important point there. I mean, look, that's the whole point. So you see how we deploy these devices. It's really slow. I mean, this is slow. It's like slow motion almost. It's nothing quickly. So what we do is you make the ball. When you have the ball shape, that means if you have just the single ball, the barbs, the anchoring parts are not working yet. So that's the moment for me to bring the coaxiality right, to do some more counterclock or anterior torque, yes or no. So when I have the ball, that's the moment to get my coaxiality right. If my coaxiality is right, I push the device out until I have a triangle. If you have the triangle shape, then you have to know your hook's already functioning. So you shouldn't start rotating and adapting your coaxiality there. If you do that, you may make some tears in the appendage. When I have the triangle, that's the moment where I look for my optimal depth. Yeah. So if I think, okay, I'm too proximal, you can easily push on the triangle to get a little bit more distality. And then you slowly push it out. If you think you want to keep your amulet lobe in place, the triangle, you even push a little bit on the delivery sheet as well. Otherwise, you always have a little bit of a jump forward from the lobe, and then you really slowly deploy a disc. So you see, it's a very well-controlled procedure, nothing rushing, and also knowing what time of the procedure you do your clocking or your rotation adjustment, and when you do your depth adjustment. So it's at different moments of your deployment steps.
That's awesome. Those are great tips. I will speak for myself. As I've gotten older, I tend to move slower in all aspects of my life, so that's helpful. But a quick question, Professor Dipak, you mentioned, how do you survey your patients after the procedure? Do you do a CT at 45 days, 60 days, 90 days, 1 year? How do both of you assess your patients afterwards?
Yeah, so first of all, I mean, these cases are in local anesthesia with ice, so these patients go right away after the procedure to the ward. We keep them still one night in the hospital to be monitored, and the morning after they go home. And then 3 months later, we let them come in 3 months later for a cardiac CT. So that's what I do. So our patients, they don't get transesophageal echo at any moment. Not pre-procedural, not intra-procedural, not post-procedural. Our patients don't like TE, and so that's what we do. And already since 10 years. Yeah.
Great. One last question as we wrap up. A question about ice and how do you use ice? Do you have certain tips and tricks in terms of the views? Do you take TEE views? And I guess even basic question is, do you see a difference between 2D ice, or are you having to use the 4D ice that gives you that gives you 3D reconstructions, or are you kind of just rewriting the book and just using specific ice type views and forgetting TE views?
Yeah, it's a very good question. Look, I mean, if I use, for the majority of my cases, in 95%, I use 2D ice. And you have to understand, if you use 2D ice, this is purely to guide your procedure. It's just to do a safe procedure. So I don't do any measurements even on my 2D ice. I do all my sizing up front of my cardiac CT. I do my entire planning, and my ice, my 2D ice, is just to do a safe and accurate transseptal puncture as inferior as possible. I park my ice catheter in the left upper pulmonary vein, so I can judge my depth of my lobe and my triangle and my ball, my triangle and my lobe. And then when I've done my implant, I retract the ice catheter from the left upper pulmonary vein. I take a mid-atrial, left atrial view, and then I put some color on my appendage, and I do a sweep over the device to see whether there is leaks. So that's my approach with 2D ice. Of course, what is the advantage of using 3 or 4D ice? That's when you don't have cardiac CT up front, when you don't have any 3D imaging up front. Of course, it makes sense that there you need some reliable sizing still of your appendage. And there, what the advantage of 3D ice really is that you go into the appendage, into the left atrium, and you can make a multiplane reconstruction of your LAA. So that's the key. Yes. So if you can do MPR, multiplane reconstruction imaging of your appendage, then you can really do accurate sizing, which you cannot do with 2-dimensional ice. So the 3D ice, the advantage of it is that you don't even need 3D imaging pre-procedurally. You can do all your sizing and your guidance of your procedure intra-procedural.
That's fantastic. Dipak, if you have like 30 seconds, if you wanted to add anything to that, otherwise we're kind of close to the hour.
No, I agree with Dr. Dipak. We still, from a cost standpoint, use TE a lot more. And again, that's just from a hospital cost standpoint, because 3D and 4D ice are very, a lot more expensive.
Awesome. Well, I want to thank both of you. It's really been my privilege to do this presentation with the both of you. I've learned a lot. It's always great to see you. Hopefully our paths will cross in the future in person. I want to thank everyone on this call for paying attention for all the questions. I'm sorry we couldn't get to all of them, but please reach out. We'll do our best to answer. And I want to thank everyone, and I hope everyone has a great day. Awesome. Take care, guys.
Take care.
Thank you so much. Bye-bye.